Thank you, and thank you so much for this invitation to speak to you today. So on behalf of the InMind team, which is made up of Glasgow University, Maastricht University and University of Nice, I'd like to thank Alzheimer Europe for this opportunity to talk to you about our study, which was a study aimed at communicating what we already know about dementia prevention to the general public. So, I argue that we have to strike a balance. I'd like to discuss the importance and complexity of the prevention message to the general public. And I'll start with a question, have we got the right balance? You know, we've seen the amount of funding it takes to develop drugs to prevent or treat or modify dementia. And, you know, obviously this is the data that was available to me and it goes up to 2012, but the UK Alzheimer's Society reported 5% of research funding up to from 1990 to 2012 was studies on risk and prevention. So obviously this is a shameless plug for more research funding to be put into you know, improving social capital and working on population health and lifestyle throughout the lifespan. But not just that, not at all, because dementia prevention needs to come into the mainstream of prevention messages that will legitimize it. And we found this very strongly from the people that we spoke to as part of the study. So this is a quote from one GP that we spoke to in the beginning of the study when we were interviewing stakeholders about their ideas about dementia prevention. And there were mixed messages from the general practitioners we spoke to, but there was a general reluctance to talk about dementia prevention, and this GP said, I would mention heart disease, yes, because there are treatments. Ideally, you don't want to raise a hair on a head if you don't have something that you can do about it. So I won't talk about dementia prevention unless they ask me specifically. Then when we spoke to people with any of the risk factors that I'll go on to discuss, obviously, people were worried and people took these risk factors seriously. So a lady from the Netherlands said, the GP asked me if I wanted to participate, and then you get such a letter and it says you have one or more of these risk factors. And then I thought, oh. And the interviewer in the next example was from Scotland, and she said, so was it that was about dementia that was interest, or was it maybe that you were thinking of making lifestyle changes? And he said, well, a little bit of both, but the fact that my father had it. So obviously, I think we're not striking the right balance, and people. It wasn't so offensive to people to discuss their cognitive health, and I really do think that until dementia prevention is mentioned in all European healthy aging policy, the way that stroke is and heart disease is, until it comes into the fold, it won't be taken seriously, not by the general public and not by general practitioners who are our army of you know, medical authority that are giving the health messages in primary care. So, on the whole, in our first part of our study, in our interviews with stakeholders, understanding of modifiable risk factors was low among both health professionals and the general public. Both groups believed that individual agency and actions were negated by non-modifiable factors, particularly genetics. And few had considered making any lifestyle changes to reduce theirs or anybody else's risk in their family. And so why is this? Why are we so frightened of mentioning dementia in the prevention messages? I think there are at least 4 jeopardies. I could probably think of more. But it's likely that many of us in this room have been personally affected by dementia. I myself am a carer of my mum who has moderate Alzheimer's disease. And I think any of us who have had some personal experience with dementia could say it's probably not a force for good in anybody's life. And since a cure for the complex syndrome of dementia is unlikely development by 2025, risk reduction is modelled to be the most effective approach to delay onset. But there are these jeopardies that mean that we still pull away from talking about it in clinical practice. And I think there is a risk that we disenfranchise the group of people who already have dementia, who may or may not have engaged in any one of these lifestyles that are risky for our cognitive health. And that's something none of us would want to do. And that is a risk of talking about dementia prevention. And it's a risk I'm acutely aware of in this setting where we have such great camaraderie between people with dementia and carers and professionals and researchers in the field. And then there's the problem of individual agency, because we know that this is a largely neoliberal idea that, you know, we tell people to change their behavior and they can choose to change it or not. And that's not quite true, because many of these things are socially mediated, and people who live in more deprived areas have more of these risk factors. And then there's the thing that dementia is a condition that weighs very heavily on the human psyche. It's one of the biggest fears of aging that we all have. And there's been research by Patricia McParland in 2014 that looked at how the public who don't have contact with people with dementia, how they describe people with dementia and what dementia is. And there were analogies of animalism, of zombies, and of social death. And these are not positive things for any of us. And so, unsurprising then that people don't want to discuss it. And that's some of the stigma that we still have to break down. And I think that, coupled with the fact that the dementia prevention message is incredibly complex, because is it really prevention or is it delay? And does it really matter? And then there's secondary or primary prevention. What are we preventing? Are we preventing the occurrence of plaques and tangles, or are we preventing the occurrence of clinical symptoms? And I think these things complicate the message. This next picture, I couldn't resist using it. It's a German picture, so I had to while I was in Germany. It's a 16th century picture called The Fountain of Youth. And as you see on the left, there are people being sick and elderly being wheeled up to the Fountain of Youth, and then they swim across. And on the right side, you can see there's dancing and feasting, and I don't know what that lady going into the tent is going to do, but it looks like fun. And I think this depicts our ancient obsession with some kind of fountain of youth. And let me say, and it's particularly in this company, I will be incredibly gracious and grateful when somebody invents some kind of cure or modifying treatment for dementia. So let me not say that I'm not in favour of research into those areas, but we shouldn't keep damaging our brain in the meantime. That's really the most simple message I have. So we designed a study that, despite all of those jeopardies, we wanted to help people to understand messages about dementia prevention and lifestyle. So the team in Maastricht were in charge of doing a big systematic literature review, and we also did a Delphi expert study, which helped us to choose 12 risk factors, and also the experts who are world experts in the field, and are all mentioned in this publication at the bottom of the page there, helped us to rank those risk factors, so that what we got was a different type of algorithm, not an algorithm of your risk of dementia, but an algorithm of your modifiable risk of dementia, which is different than what had previously existed. And we called it Libra, because we love balance, Lifestyle for Brain Health, and we came up with these 12 risk factors of some of them are protective and some of them are risk. So high cognitive activity, which is protective, depression, which is a risk, health, Mediterranean diet, midlife hypertension, midlife obesity, smoking, cholesterol, physical inactivity, low or moderate alcohol intake. And then we had this problem of these 3 diseases, which we know are highly associated with the incidence of dementia, but it's kind of dichotomous. If you have it, your risk is higher, and even if you manage it well, we don't have the epidemiological evidence to say that our risk lowers because we have well-controlled diabetes. But in terms of a communication tool, it would be highly irresponsible of us to say, it doesn't matter if you manage your diabetes or not. So, of course, diabetes, chronic kidney disease, and and coronary heart disease are in the model, and they make up a portion of the model that we remind people to manage well, and I'll explain that more. So here are our risk factor. Each risk factor is associated with the question, a cut-off value as to whether the person would have that risk factor or not, and those cut-off values are based on the national cut-offs from the Department of Health. And as you can see, if you live in the Netherlands, it's okay to have higher cholesterol than other European countries. And so we localized this as much as possible. And then we had to validate our model. So did our model actually, could it be used to predict people in existing data sets who were more at risk? So we aimed to confirm the predictive value of the Libra score. And we used the Maastricht aging study in the first instance, which has just under 1,000 people and 143 cases of cognitive impairment, 16 years of follow-up. And it was brilliant because it had 11 of our 12 risk factors were looked at in this data set. And then we subsequently used the Describer data set, which is a bigger sample, but as you can see, it only had 9 out of our 12 risk factors, so we weren't able quite so closely to relate our particular model to the Describer data set. But nonetheless, there were just under 1,000 incident cases of dementia in that data set, so it was quite a powerful data set for us to use to test the model. And in the validation, we found that the MASS data set, the Libra score, significantly predicted future risk of dementia as well as risk of cognitive impairment, and effects were independent of age, gender, and education. And in the Describer study, in midlife, there was a significant association between the Libra score and dementia risk, but not so in late life. And we do have to do much more work in validating the algorithm in further data sets, and that work is, well, if we get some funding, it'll be underway. So the main objectives subsequently were to convert the Libra model into an online system that accepts the information about the 12 risk factors and delivers a supportive online environment with a personalized risk reduction strategy, involves stakeholders in the design and validation all throughout that process. So the 12 risk factors were transformed into a series of questions, and these questions always, wherever we could, we would use research-based questionnaires so that we had valid information about mood, physical activity, cognitive activity, not just the measures that we thought we should take, but valid research tools. And we had two key questions. Does the in-mind intervention, the profiler and the online support environment, improve people's brain health? And what do users think about the intervention and prevention of dementia? And we conducted a feasibility RCT. So we identified people eligible for the study. So that was anybody who'd been seen by a GP and was found to have one or more of our 12 risk factors. We recruited them, we took a series of baseline measures so that the full in-mind profiler was gone through with everybody in the sample, and then they were randomized anonymously by Glasgow University and randomized into either the in-mind intervention, who were given their profile and put into the support environment, and the control arm, who did get their profile but only after the study had finished. And we followed them up at 3 and 6 month intervals. So these are just the randomization numbers. The Netherlands were particularly good at recruitment. And the baseline characteristics, the population we were looking at, I should have mentioned, were aged between 45 and 60. So we had really good similarities between there was no significant differences between the control arm and the intervention arm. And we asked people, why did you join InMind? Why were you motivated to join the study? And these were the 3 top reasons that people would. And it was the proximity to someone with dementia, particularly a parent or another family member. They were worried about their own memory already, although they didn't have any objective memory problems because they were screened. And they were thinking about making lifestyle changes anyway, and these were the 3 leading reasons why people became involved. So the people in the intervention group got an online support environment that included Libra profile and score, personalised evidence-based information on their risk or protective factors, signposting to other existing and legitimate support. So we're really trying to help people see legitimate information, because one of the jeopardies is with the fear of dementia and the complexity of the messages, it has given rise to a whole industry of dementia prevention diets and drinks and various compounds that have very little basis in science. And because of this, we wanted to try and give the most legitimate evidence that people could access easily in a one-stop shop, and only give them the information that was relevant to them based on their own profile as well. So this is what the support environment looked like. So when you filled in your profile, which took about 15 minutes, you would get a profile that said, the blue area is keep it up. So these are the things you're managing really well, and then you have a small explanation that this is great and that this is why it's important for your cognitive health. And then the green area, so this person must have had one of the diseases that confers risk, and they were being informed to remember to manage their diabetes or renal disease or heart disease well. And the yellow was room for improvement. So these were the risk factors where they could do more to support their future brain health. And then when they click into one of those risk factors, it gives them more information. And here this person's getting information about cholesterol, keep this up. So they're doing really well with their cholesterol, which is great. And they were told why. So the major take-home messages. Knowledge of modifiable risk factors for dementia are low in both the public and practitioners in primary care. The InMind Profiler is an evidence-based system to assess the presence or absence of 12 risk or protective factors for dementia in people in midlife. And telling people their brain health score seems to be feasible and acceptable and doesn't add to primary care workload. In other words, it didn't lead to a whole procession of people going to their GP after they'd filled in the profiler worried about their cognitive health. Recruitment was a huge challenge, and we chose to include general practitioners in the recruitment because we felt it was very important not to disenfranchise them in the dementia prevention message, but it really proved to be a huge bottleneck, and we had people approaching us saying, I'd be in your study, but we had to make them go through the study general practitioners, and it was a mistake in hindsight, and I think just general population recruitment would be better. And I think very key to this, and pertaining to the point I made earlier about the fact that there are inequalities, I think what we showed with this study is that when we do an online intervention, these inequalities are reinforced. So it was very difficult to recruit people from areas of deprivation. And, participants didn't run off to the GP or the practice nurse every time they filled in the form with any major concerns. So recommendations for prevention are currently undermined by a lack of well-designed, properly scaled clinical and population-based trials. And we can see that this is improving, and we've seen in the presentations earlier some major studies into dementia prevention. I still don't think it's enough. I think there's huge potential in this area, and we need to do more. There's a compelling need for robust research evidence. And we call on anyone who'll listen, really, to support large-scale research investment into these urgently needed population-oriented trials, to work with national governments and research funding bodies to encourage collaborations towards a concerted objective, because balance is key to life. And if any of you are interested in looking at your own Libra score, please go to the website. It's free and available to anyone, and you can go and see your Keep It Up score and your Remember to Manage Well, and get the most legitimate advice that's available on improving your lifestyle for brain health. Thank you very much.